I used to be able to do 5 things at a day, you know. Now, if I do 2, I feel this has been a monumental day. I could go to the grocery store, or I could go to the park. I can't do both.
I don't work. I don't work. No, I don't work anymore. I stopped working and I stopped going to school. I try to keep up with what's going on in the world, and I'm happy with it. I'm content. Let's say content.
I don't feel very free in my life. I'm not allowed to drive. That's pretty confining. They say, oh, well, you can get a taxi, you know, but you lose the spontaneity of life if you're confined. And here I am confined, but I accept it. But I miss it, you know.
My least favorite thing that happened to me is that my family took my car away. And it was a morbid experience for me. It just changed my entire life. Made me feel dependent, old, and I didn't have any say in it.
I have a daughter. I once said, I wish I had been the daughter she is. I've never seen anything like it. She is, in a sense, a caretaker, which that bothers me, you know. She takes so much responsibility for our well-being. She orders my groceries, you know.
My daughter can make me very happy.
How does she do that?
She just talks to me, and whatever she says, I think it's really funny.
I feel that it's a constant tug with my children. They would prefer that I had someone with me frequently. I've taken care of myself practically my whole life, not having had a mother. It's too difficult for me to allot that responsibility to my children.
I think what happens is she becomes critical because she's frustrated. I think that's what it is, that she sees me not being me or something, or that I'm doing something that I think I can do, but I really can't do. We argue, you know.
My father was 52 when he died. My mother's 70. So no one has taught me how to behave, you know, how to live this long. So I hope I'm doing it right.
Welcome to the Daughters InSanity community and tonight's event, part 1 of a 3-part series. I'm Ellen Breslow Newhouse, one of the co-founders of Daughters InSanity. And as Hallie explained at the top of the program, when we created this group, we were looking to find sense, sanity, and humor out of our own precarious predicaments as primary caregivers to our elderly parents, most of whom were struggling with waning independence and some level of dementia, which you might have gotten a little hint of in that video. What we discovered, however, is that this is an intergenerational moment affecting the entire family, us, our parents, and the younger generation too. Tonight, we're going to explore the unpredictable behaviors, emotional challenges, and physical limitations our elders are experiencing. It's pretty crazy and stressful, we know. Our mothers and fathers have, in some cases, become unrecognizable. And we're taking on the role of the parent as they become more and more dependent upon us and more childlike. This evening in part 1, Are You My Mother? We'll step into the shoes of our aging mothers and fathers. What do we know and what can we assume they are experiencing, and how will that help us become better caregivers? Part two will look at this life chapter from the perspective of us adult children and caregivers. And part three will explore how we can prepare our children now so they can have an easier time with our own end of life when that time arrives. Tonight, we have two terrific experts in brain health. Dr. Lindsay Gorin, geriatric psychiatrist and neurologist at NYU Langone, and assistant professor at NYU Medical School. Excuse me, I'm just going to let a couple people in here. And also Molly Fisher, Director of Program Innovation and Education for Inspire Senior Living, LCSW. Formerly at Alzheimer's Foundation, Molly is a memory care specialist with expertise in educating individuals to find quality of life and meaningful living with Alzheimer's disease and other dementias, as well as providing therapeutic support for adult caregivers. Molly also maintains a private practice in New York. Please feel free to put your questions in the chat throughout the program. There'll be questions and answers following their presentation. We're also going to right now post Dr. Gorin's and Molly's contact information in the chat if anyone would like to follow up privately. A couple of reminders: you'll be muted throughout the presentations. Don't forget to put your questions in the chat. And be sure to make your view on speaker. It'll provide you with the best view. Now I'd like to turn the evening over to Dr. Gorin.
All right, thank you so much for that lovely introduction. And it is just so wonderful to see everybody here. And that video was amazing. I think, what I'm going to be talking about today, I can just share my slides here, is sort of my perspective as a neuropsychiatrist, kind of looking at these symptoms. But I think one of the kind of most important things is just having this community of people who can kind of do this with you. And so, when these ladies asked me to do this talk, I jumped at it because I just think this is such a wonderful thing that you guys have going. It's so important to have this connection with people and to sort of share strategies and, kind of connect over this. So, what I'll talk about today. So I'm a neuropsychiatrist. I did training in neurology and psychiatry, and my interest is in primarily people who have mood and behavioral problems related to brain issues. So that includes dementia. I also see younger people with brain injuries. But a lot of my role involves working at NYU's cognitive neurology practice, where I see people who have dementia, kind of across the full spectrum, people who are presenting just with some kind of early symptoms. We're doing the evaluation, or many of the people I see are people who are kind of later, have sort of moved later into the stages and have some more severe changes in cognitive function and mood and behavior. And so as a neuropsychiatrist, this tends to be a lot of sort of what I end up trying to help people with. And so what I'll talk about today is just sort of, there's a lot that I wanted to put into this very short talk, but just some kind of important points that I think might be helpful to know just from my perspective as kind of the medical provider. But I think, a central theme that I'll touch upon here through all of this really is that I'm a very small part of this. And, as a physician, we really are kind of only a piece of the pie, and really it takes a team approach and sort of a network to work on this. So this is from, so just nice graphic from the Alzheimer's Association, which I think probably you all are familiar with, but if not, they're a very nice organization with a lot of resources that sort of great to check out. And so this is, from their kind of most recent kind of dementia care practice recommendations. You can see here the overall idea is that this is a person-centered focus. We're really trying to kind of keep the person at the center, who this person is, what their life, is, what they want their life to be, and sort of all of these things around can support that. And so what I'll be talking about here, I'm this little piece here, the medical management, but this is, all part of this kind of overall network of helping people out. So what role does a physician play in dementia care? And so I have here, there are different kinds of doctors who you might see for dementia. You might see all kinds of these people. You might see, just one. Neurologists, particularly cognitive neurologists, are often people who are doing some of this assessment, but depending on where you're living, if you don't have access to that, you might see your primary care doctor, or a geriatrician might be someone who you would see for this. Geriatric psychiatrist as well might be a kind of doctor you would see, and it depends on sort of what the different symptoms are. Sometimes people will have, a couple of these doctors. I know that I myself often will work with geriatricians, or sometimes, I'm the neurologist working with a geriatric psychiatrist and sort of, and the rest of the team kind of trying to give people some support. So as the doctor, one of the main things that, sort of when I teach my residents about, what are we doing in a dementia practice, I think one of the primary things really is to confirm the diagnosis and exclude what we call dementia mimics. So things that look like dementia, but are potentially treatable. So I'll get into a little bit of this later, but things like depression or vitamin deficiencies or low thyroid or things like this that are, potentially things that you treat it, the cognitive function gets better. So what I really, what I view as a very important part of my role is kind of doing the full medical evaluation to really kind of get as much confidence as we can that, this is a dementia and hopefully be able to specify what type of dementia we think it is so that we can try to plan for the future and kind of build expectations for what might be coming later. Sort of associated with that, so providing education and supportive resources, connecting people with people and programs that can be helpful, and then directing the medical treatment. And so really what that means is really primarily one, trying to optimize the person's overall health, managing their other medical issues. So for example, very common overlap that I see is people with cognitive problems who might have we call vascular risk factors, either cardiac disease or high blood pressure, high cholesterol. So making sure all of that stuff is taken care of, because if those are not being managed correctly, that can make the cognitive function worse. And that's often where I'll work with a primary care or a medical doctor, geriatrician. Next, in some cases, and this is like only relatively recent that we even have this option, but there is one drug now on the market. I'm not going to spend a lot of time on it, but this drug Aduhelm, perhaps you guys have seen this and the controversy around it. This is a drug that does target the underlying biology of Alzheimer's directly. We are not using it here yet. There are a lot of kind of problems with it, but potentially this or others like it in the future might be something helpful that we could do, and that would be something that the medical doctor does. Also clinical trials, we refer people for those as well, kind of drugs that are being investigated, but that are not yet on the market, depending on kind of what sort of problem we think is going on. But the primary thing that I do is really try to coordinate both the kind of pharmacologic and non-pharmacologic strategies to help lessen symptoms, right? We can't right now cure dementia, unfortunately. We're working on it, but in the meantime, we're just trying to reduce symptoms. And particularly, as I was saying, the ones that often are most distressing that I often get involved with are behavioral and psychological symptoms. The goal of all of this, as I was saying, and sort of is really, as I was kind of mentioning, to support a person-centered plan of care. And, we try to think of all of this in context of optimizing the person's quality of life, really trying to maintain functioning and independence as much as we can, really trying to preserve identity and dignity for everybody involved. So the person with dementia, and then also the people who love them and who are taking care of them, and really allowing everybody to have a life that is meaningful and that is consistent with who they are. So what are behavioral and psychological symptoms of dementia? So these refer to the changes in mood, behavior, or personality that can start before cognitive symptoms or can occur in parallel with the cognitive symptoms of dementia. They can be often more distressing than the cognitive symptoms themselves. They are caused by disruption of important brain pathways, which I'll talk about in a minute. But it's important to note these are not a reaction to the stress of being ill. This is not the person is coping poorly with, getting this diagnosis or having their freedom limited. This really, I think much of this is related to chemical changes that happen in the brain related to dementia. And the behavioral and psychological symptoms of dementia really, often are the most sort of difficult and time-consuming and often financially costly elements of dementia. They're estimated to account for up to 30% of the U.S. economic cost of dementia, sort of trying to manage these symptoms. So they are a major issue that we're working on all the time. This came out very big, but I was trying to show you the sort of 12 domains that we think about the different kinds of symptoms in. And so the way I think about them, I sort of group them into the way I think about them mentally, but so there are the psychosis symptoms, that's delusions and hallucinations. And this refers really to a true break with reality. Delusions being, you believe something is happening that's not happening. Often in dementia, this can be related to a cognitive problem. So if you have a memory problem and you're forgetting where you've put things, there might be a delusion that somebody is robbing you or stealing from you. Some other more concerning delusions can be about, the family members not being who they say they are, or another common one is a delusion of infidelity, believing that your spouse is cheating on you. So these can sometimes be pretty problematic. So we look for those. And then associated with that is hallucinations. And so this refers to a perception of something that is not actually there in the environment. That can be hearing voices, or more commonly in dementia, often is seeing things, either people or animals. And sometimes those are not distressing. I've had people tell me, they see little people kind of performing Broadway numbers, and that's actually enjoyable for them, and we don't treat that. Sometimes they are, they can get scary. And so we, sort of want to identify those. In the mood category, so depression is a very common symptom, and sort of the whole spectrum of that, from just kind of slightly low mood to being really clinically severely depressed. I'm going to get into depression in some detail in a little bit. The opposite of depression, euphoria, sort of inappropriately elevated mood. Anxiety, I kind of put in here as well, and irritability, which can look like just kind of snappiness or low frustration tolerance. Often kind of runs with these mood symptoms. Then there's a motivation category. So the most prominent one here is what's called apathy, which I'll talk about a little later, sort of a lack of interest or engagement in things. And then the flip side of that, disinhibition, kind of being overly motivated, sort of doing things, kind of not really being able to sort of withhold your behavioral response to things. Next is body function. So this can look like changes in movement patterns, so either restlessness, pacing, or sometimes the alternative, kind of being very slow, moving very slowly. But the more problematic ones are usually the kind of moving around a lot, either doing repetitive behaviors, tearing up papers, kind of collecting things. These can all be part of this. Sleep and nighttime behaviors can be disrupted. People can have their day-night cycles be flipped. Or might be waking up a lot at night or sleeping a lot during the day. And then appetite and eating. So appetite can go in either direction, sometimes can increase, sometimes can decrease. Often people will forget to eat and sort of need to and have kind of lost access to the body sensation that tells them that it's time to eat. And so that can be part of this as well. Sometimes people's food preferences can change. And so often carbohydrates and sugar and dessert type things become more appealing, even to people who have been health nuts their whole lives, sort of sometimes can change their taste preferences. And this again is a brain thing. And then I have agitation and aggression here in its own category. And this really, is often can come on its own, but often is driven by other symptoms. It often does come with some of these other symptoms, or can, often we sort of think about it as a response to some stimulus, either in the environment or internally, that is distressing, that the person is trying to communicate with you about. But sort of often is the kind of end result of a lot of things happening. And so when that's going on, we try to sort of piece together kind of what are the things contributing and how can we address them. So thinking about specific symptoms in dementia, so apathy and depression are by far the most common. You can see here apathy affects almost 50%, almost half of people with dementia at some point. Depression is also right up there with 42%. And then below that is aggression, sleep changes, anxiety, irritability, changes in appetite. And then down here, the delusions and hallucinations are less common, but are very problematic, when they do happen. And so we're always looking for them, unfortunately are not as prevalent as apathy and depression. So what causes these symptoms and why is there so much variability? And so really, we think about kind of multiple factors going into these symptoms. On the one hand is individual factors, which I'll talk a little bit about, but there are also factors outside of the individual. So caregiver factors, kind of either related to the relationship with the caregiver or other things going on with the caregiver, or environmental factors, things like, it's too noisy, it's too hot, it's not, the sort of environment is, there's not enough stuff there that's interesting, or it's sort of overstimulating. So, these are all things that we think about when we're trying to kind of figure out what is driving some of these symptoms. So my focus here, I'm going to talk more about some of the individual factors and then about a couple of the specific symptoms. I know we have Molly Fisher, who's an expert on more of the kind of behavioral and lifestyle and communication relationship type factors, which we'll get into later. So thinking about individual factors, I think about this as, sort of fundamentally, you have who this person is, right? And so there is this, the person's lifelong personality traits, like what is their normal response to stress? How do they normally view events? What is their normal communication style? Is there any prior psychiatric stuff? Did this person have depression or anxiety in the past that might get worse now with dementia? Particularly important here also is trauma history. So if people were, sort of had traumatic events either growing up or, in adulthood, and sort of, whether or not they had sort of problems related to that when they were younger. Sometimes in dementia, as people are aging, some of these things can come out, and you can people can be kind of responsive. We respond differently to different people, or sort of be triggered by certain things that are relevant to the, knowing that trauma history. And so that can be helpful to know. What I should have here also is any kind of previous, we call neurodevelopmental disorder, anything like a learning disability or attention deficit disorder, other things, other ways that your brain might have been a little bit sort of different from what we call neurotypicals in the first place. So things can look different, when you sort of develop a dementia. So on top of who this person is, and you have the changes from dementia, right? And so this, with every dementia, there is a loss of the neurons, the brain cells in certain circuits. And associated with that, a loss of the neurotransmitters. These are the chemicals that the brain uses to communicate and send messages. And so these vary depending on the different types of dementia, and also which parts of the brain are affected. And certain types of dementia prefer to, start in different parts of the brain, or will affect different circuits, and so can produce different symptoms. And then on top of this are kind of the other things that can come up with living with dementia. So medical illness, pain, hearing or vision impairments are very important to sort out. Language impairment, which can come from the brain changes. But so these are all things that might kind of interfere with either the person's comfort level or their ability to communicate what they're experiencing, and can cause some of these symptoms. All right, so thinking about the brain stuff, so these symptoms, behavioral psychological symptoms, really most often arise when dementia affects the frontal and temporal lobes of the brain. And so the frontal lobe is here in purple. And so one of the main things that the frontal lobes do, particularly what's called the prefrontal cortex, is a cognitive domain called executive function. And so this refers to our ability to plan, make decisions, to think about our goals, and to sort of manage our behavior in the service of those goals, and to withhold behavior that gets in the way of those goals. It also involves what's called cognitive flexibility. So being able to adjust your thinking and update your behavior in response to new information, not getting stuck on one idea, but being able to say, okay, there's new data, so I'm going to shift over to that. Related to this also is impulse control, sort of being able to choose how you're reacting in a certain situation and not just kind of have an immediate response. Executive function is a very important domain that really can be impaired across all types of dementia and other kinds of brain injuries, and often is a big sort of one of the major contributors to whether people can live independently and how much people are able to do on their own. So somebody with a memory problem who has good executive function is going to be able to take notes, work around their memory problem, sort of make plans that account for the memory problem, and may be able to be independent for longer than somebody who has a memory problem and an executive function problem, who is not able to sort of account for the fact that they have the memory issue. So related to this are the problems that come from temporal lobe involvement of dementia. And so the temporal lobes, their primary purpose really is dealing with memory and also emotional processing. And so the temporal lobes, are sort of one of the primary areas or first areas that are involved in Alzheimer's disease and are the reason that people start to lose their memory. But also problems here can cause trouble with regulating the intensity of your emotional response. And this partly is related to pathways that link up with the frontal lobes, and there's some communication between those two. But sort of that regulating sort of an emotional reaction and deciding how much of it to express. Related to this also, the temporal lobes are involved in interpreting body information. So like, when your heart rate goes up, and you can kind of think about like, well, is my heart racing because I'm panicking and because I'm about to have a panic attack, or is it because I just walked up, 7 flights of stairs? And so you can sort of put it into context. And so, the ability to interpret that body information becomes a little bit more difficult when there's a temporal lobe problem. And then also related to this is the temporal lobes, because they have this memory and emotional processing link, they essentially provide memories for context so that you can, you feel the emotion, you kind of review the situation, and then you review your memories and decide, what's the right behavior in this situation relative to the things I already know. And so if you can't access those memories well, you're going to have a hard time learning and sort of adjusting your behavior to new situations. And so the combination of these things often is, in general, when people are having these kind of major changes in mood and behavior, it often is related to these frontal and temporal lobes. So in general, how do we approach managing these symptoms? And so the primary thing really is describing the problem. And often that is very hard because there can be, it can just seem sort of, often there's like a lot of chaos happening. The person is, either very upset. There's a lot of things going on. It can be really hard to say actually, what is happening? Is she anxious? Is she depressed? Is she sort of, having some physical problem? And so kind of really getting some detail about what's happening. When is it occurring? Are there certain people it happens with? Are there certain other triggers? And did anything change recently? And really getting some detail about that can be helpful. And then you want to think about, what are the sort of potential driving forces here? So could there be a urine infection that we're not treating? Or could there be, is it that, this happened actually when the pandemic began, as I'm sure you all experienced, when everybody's routine was dramatically disrupted and nobody could see their family and people were really disconnected from their loved ones. This was a major stressor, really caused a lot of kind of mood and behavior changes for people, even for people without dementia. It was very hard. So then after that, you want to think about non-medication strategies. And so, I'll leave these for Molly to help discuss, but, these are really the kind of primary thing that we're trying to optimize. And then if that is not effective, we will think about targeted medication management. So, medications, and I'll focus on this because as the MD, this is often what, I'm doing, but medications are sometimes needed to manage these symptoms. But an important point about them is that they really are extrapolated from the way we use medicines for psychiatric problems, for primary psychiatric illness. And so the brains of people who were in studies for psychiatry medicines are just very different from people with dementia. So it is not clear that they are the same, that we can apply them the same way. And in fact, that's what we see in real life, that these medicines are, not particularly effective. They sometimes can help, but they sometimes don't. And they often have, risk, more risk of side effects in people with dementia. So we are cautious with them. We're thoughtful when we use them. Sometimes they are necessary, often when there's, really bad psychosis, or, if people are, thinking that their family member is an imposter and they won't let them take care of them, that's a problem. So we will use medicines for things like that, or for very dangerous behavior, or really significant depression or other emotional distress. But really these medicines should not be used as a shortcut to avoid making the environmental changes and behavioral changes that we know can be helpful. And in general, the best approach is really almost always a combination of non-medication and medication strategies. So just best practices for using medicines in dementia. So we say start low and go slow. So I will start like the lowest possible dose. And, even then if I can cut that pill in half, we will cut it in half. And just, really try to be cautious. I like to only make one change at a time, just because if you're doing multiple things, even though there's often I feel the urge to do that. And I'm sure that, some of you have been there where it's like, this is very bad. We really want to fix it now. If we make multiple changes, I'm not going to know what did what. And so I really try to kind of do it sequentially. So we really have a sense of what is responding and what's not. When there are multiple symptoms, it's helpful to try to prioritize them. And so think about like, what is the most distressing? Which of them is really, are any of these symptoms really putting this person at risk of, kind of being unsafe or getting hurt. And then thinking about also, how are these symptoms linked? And so you can think about if there is maybe, if there's some agitation, but really it seems like a lot of it's from, intense anxiety, then treating the anxiety, sort of can help. You sort of want to find what's underneath and treat that. We try to avoid multiple medications, what's called polypharmacy. This often happens, just especially if you're seeing multiple doctors, everybody just throws their own medicine on. So we try to avoid that. And, one thing that can be helpful here is actually taking some medicines away that could be causing problems. But sometimes we do need to combine medicines that have different mechanisms. And, I'll do that. Often I'll try to keep both doses low and see if we can get the benefits of both without hitting the side effects from either of them. So I'll talk a little bit just about a couple of the two kind of most common symptoms. So depression being the first one. And so there's, a lot of links here with dementia. And so 20 to 25% of people with dementia experience clinically significant depression. That meets criteria for major depression. This is as opposed to 13% of the general population. Depression can be associated with dementia in a few different ways. So we know that actually a lifetime history of depression before age 60 is associated with higher risk of dementia, so 2 to 4 times. Depressive symptoms later in life can be, as I said, sort of the earliest signs of dementia. Sometimes they can come before the memory problem. And then depression can be associated with faster cognitive decline before and during dementia. And then finally, depression can cause cognitive problems that mimic depression or mimic dementia, what's called pseudodementia. So, this is sort of, it's a lot and sort of a little bit concerning about depressions or anything that we can do about it. And actually, yeah, it seems that there is. So depression is increasingly being identified as a modifiable risk factor for dementia. So we know that chronic untreated depression over time puts stress on the body, is associated with inflammation, and this can impair brain function. And then, kind of along with this, there is evidence that the more severe your depression, the kind of worse it is. So, more severe episodes, longer episodes associated with higher risk of dementia. But treating depression can actually reduce your risk of progression to dementia. And so there are a couple of studies in people with mild cognitive impairments. So these are people who don't have dementia, but have mild cognitive changes that suggest they could be at risk for dementia, and who also had depression. Treating with SSRIs, as a selective serotonin reuptake inhibitors, antidepressants, was associated with slowed progression to Alzheimer's by 3 years. Similarly, another study of patients who had mild cognitive impairment and depression who were treated with antidepressants had less cognitive loss and less brain atrophy compared to untreated patients. So, there's increasing evidence that antidepressants, in general, across a lot of different disease categories, can reduce inflammation, can improve brain kind of neuronal growth and neuroplasticity. We actually separately, there's a lot of interesting literature using it for people who've had a stroke, that the antidepressants, the serotonin antidepressants can help with the brain plasticity you need for stroke recovery. And actually antidepressants might even help clear out amyloid plaque in the brain. And so, identifying and treating depression in people with cognitive impairment is very important for quality of life, and then also might be helpful for longer term benefit. Just a review of the symptoms of depression so that you can recognize it. So the core symptoms are really one or both of either a low or irritable mood or decreased pleasure or interest, what's called anhedonia, and then some other features. So feeling guilty or worthless, fatigue, loss of energy, problems with concentration, obviously thoughts about suicide are a sort of red flag for this, big changes in weight loss or gain, big changes in how quickly or slowly you're moving, and then changes in your sleep, either more or less. You can see a lot of those actually do overlap with the symptoms of dementia. And actually depression in later life can occur without feeling sad, so people will, don't always say I feel sad, but they can be depressed anyway. Depression later in life commonly does involve problems with concentration. And so it is, important to sort of think about, could this be depression, and treat it if it is. When we treat it, so I always think about, as I said, could this depression be playing a role in this cognitive problem? And if it's possible, I usually try to treat it, and I just sort of, you see what happens. Lifestyle modifications are the kind of major intervention here: exercise, healthy diet, increasing social engagement. Psychotherapy can be a very helpful tool. And I just want to say here, I tell actually my general psychiatry colleagues this as well. You actually don't have to remember what was said in therapy to benefit from therapy, right? So the memory problem that happens in Alzheimer's, where you are sort of having trouble remembering things that happened, things that were said, is a separate network from the memory of kind of emotional experience and being able to build healthy habits. So you can actually get that from therapy, even if you don't remember that you learned it. And then antidepressants can be helpful for more severe symptoms. So the second most common symptom here that I mentioned is apathy, and this can be very hard to distinguish from depression. I just want to kind of make a point about this here. So apathy is a state of diminished motivation in the presence of normal consciousness and moods. If people just are, they're not depressed, they're awake, they just are not interested, they're not motivated. And really this is a frontal lobe problem and is related to, it's sort of an executive function issue related to difficulty choosing a behavioral plan, following it through, and coming up with ideas for things. Can look like being indifferent or sort of not being empathetic, can look like needing prompts for activities. And often this is more distressing to the caregivers, to loved ones who are kind of looking at someone who maybe used to love to read, used to love to exercise, and now just kind of doesn't want to do anything. And so, when we treat this, we think about sort of what are the goals and, what are we kind of trying to help this person do? How distressed is this person by this? Sometimes even if the person is not bothered, but it's really getting in the way of sort of family events and, and sort of just making it hard to take care of them, it can be worth treating. And actually, one of the main ways of treating it really is kind of just adding structured activities and enriching the environment. I think I may have told this story when I spoke to these ladies last time, but I have a patient who, sort of really had pretty significant apathy related to Alzheimer's. And, we tried medicines and we couldn't really get anywhere. And then she ended up just briefly in a rehab hospital following an orthopedic injury. And the 3 hours of therapy a day, like, turned something on. And she just was like so engaged. Everybody was like, I thought you said this person didn't do anything, and she just was like so chatty with all the staff. And so just having people around, having activities, kind of having people engage you in things you like can really go a very long way. And then medications can sometimes help as well. We sort of consider those on a case-by-case basis. So I'll just say here on my last slide, medical management of these symptoms really is only a small part of the puzzle. And so as a physician, as I said, I can help sort of clarify what kinds of symptoms are happening, help evaluate for underlying medical causes, and sort of prescribe medications when those are, potentially helpful. But really, this works best in the context of a team-based approach, and really the best data for any intervention in dementia, really are programs that provide caregiver support. Those are sort of the things that really show the most benefit to help you as the caregiver be able to provide these kind of other strategies that are really helpful to your parent or a loved one. And so even these small behavioral or lifestyle changes, so like adjusting your light exposure or changing the way that you communicate, these can yield very big results. And so with that, I will hand it over to Molly.
Thank you so much, Lindsay. Hi, everyone. Can you all hear me okay? Okay, I think so. I'm like asking you, like you can respond to me. You're all muted. Okay, let me share my screen and bring this up. I don't know how much time I have. And so if somebody wants to just write in the chat how much time I have, that would be great. And then I'll get, oops, nope, you don't want to see that. And then I'll go ahead and get ourselves started. Okay. So thank you all so much for taking the time to be here tonight and really to be here for yourselves and for each other as a community of caregivers. We're going to go ahead and just kind of complement what Lindsay said and talk a little bit about how we can cope, how we can manage, how we can freak out, and anything else that really comes along as we're dealing with our person who might be living with the dementia. So our lives as caregivers, the most important thing that I always like to tell people is to give yourself some grace. It's really hard what everyone does every day as a caregiver, whether you're a family caregiver or a professional caregiver. This is just really tough. And I kind of speak from both sides of this. I had a parent who was living with a dementia, and then my work as a trained clinical social worker, but working in a variety of different settings. I give and give and give all day. And so take a moment and just give yourselves a round of applause for being you and being amazing, whether it's as a daughter, a son, a partner, a parent, whatever it is, like you guys rock. So thank you for all that you do. As Lindsay mentioned, dementia such as Alzheimer's disease these things don't happen in a vacuum. It's not just like, oh, here's your, here's your illness, here's a pill, and everything will be okay. This is pervasive. It is a degenerative illness. There is no cure. And so we need to try and figure out what we can do as this illness impacts pretty much everything around us, and not just for the person, but as I think Ellen mentioned in the very beginning, like it affects us as adult children, as partners, or whatever your relationship may be. And so I think it's important to acknowledge that, and again, to validate that this impacts you. And sometimes it can feel as though it's impacting you more than it's impacting the person that we're working with. So what I want to focus on just briefly, and then I'm so much better with questions and conversations, and then we'll kind of go into that Q&A with Lindsay and I, and you can add whatever questions you have for me in a chat, is pretty much understanding these different behaviors that Lindsay was mentioning. As she mentioned, like due to the very nature of this particular illness, what we see is an inability to communicate with language like we once did. And so if I no longer have the ability to speak with my words, I'm going to show you what I need or what's happening with my actions. And so this can lead to what's often labeled as problematic behavior. And what each and every one of us have to try and do is figure out the unmet need. And so sometimes it feels easy for me to say this. It's one of the funner, right? I need coffee. It's one of the more fun parts of my work every single day, is trying to cultivate that culture of curiosity and really try and figure out how I can solve the challenge that the person that I'm working with is having. And if we can try, and I know it can be so hard, but even if you as a primary caregiver can take just a few moments in each of your day and try and come at the problem with that idea of like, well, let me be curious. Let me try and figure this out. And even if you just give yourself a minute to do that, even that minute can be really helpful for you. So figuring out what the unmet need is. And oh crap. Okay, there we are. And so, so I go ahead and take a look at it in 3 different buckets of the behavioral triggers. What is actually happening? Is it something that's emotional? Is it something that's physiological? Is it something that's environmental? And Lindsay touched on all of these things. We just have different graphics on it. So I like to think about, let's say if my dad is really bored, okay, he's going to go ahead and he may go to sleep. And then my mom gets really agitated because he's sleeping. And why isn't he doing more? Well, it's because he's got nothing to do, because he doesn't know how to go ahead and make himself active like he used to because of his dementia-related illness. And so if we can try and figure out that dynamic, and again, it's the third party kind of coming in, not the primary caregiver, but that helpful adult daughter, I'm going to say, oh, well, why don't we go ahead and give him some of those structured activities that Lindsay mentioned? And we might see a reduction in that boredom, a reduction in that oversleeping, which then keeps him up at night, which can lead to increased anxiety for him, for my mom. So that would be boredom. I work in a senior living center at the current time, and what we see if there is boredom is people will try and pace, or they might get anxious, and they might try and leave without us. So the interesting thing that I call going on an adventure without me. The interesting thing when we see somebody trying to get out of an apartment or get out of their home or wander, right? Each and every one of us, like if you're bored at a party, or you're having a terrible time at dinner with friends, you can just leave. Oh, you know what? My kid needs me. Oh, I'm sorry. I just came down with a stomachache. I got to go. And you can leave, right? Because this party stinks. Our individuals who are living with dementia, they can't leave. So if they're not comfortable, if they're not stimulated, if they're not engaged, if they don't like your perfume today, if they don't like your face today, they're going to be like, listen, I'm out of here. And they're going to want to go. And if you say, no, you can't go. This is your home, or you've got to stay here, or we're not ready to go yet. They're going to be like, screw you. I'm an adult. I'm going to go. Right. And so that's what we're seeing when we see people trying to leave, or we have that kind of tug of war, like I like to call it. So you're like, no, you can't go. Mom is saying, yes, I can. No, I can't. Yes, I can. And you feel like you're dealing with a child, but really you're dealing with your 90-year-old mother, or your 85-year-old father, whatever the case may be. And then all this conflict comes, and then you're exasperated, and then you just want to scream, and then you just want to push mom out the door because you're like, you know what? Enough. Fine. Go. I don't care. See ya. Right. And then you feel bad about it, and then you feel guilt, and then you can see how that cycle. Any of you relate to this cycle? A few of you, maybe. It can be so stressful. And so what it comes down to usually, again, is that emotional piece. Anxiety, boredom, fear, loneliness, disorientation. Just because a person might be in the room or in the apartment or in the home with you doesn't mean they don't feel lonely. And that can also go for all of you. You could be in a room, you could have a ton of friends, you could have your, therapist, everything else, and you could still feel terribly lonely. Perhaps you don't feel seen, perhaps you don't feel heard. And the same can be happening for our individual living with dementia. And I know it can be really hard with all of the stuff that everyone on this call is dealing with, but if you can try and keep that in mind, what must it be like to be my person who's living with this dementia? Putting yourself in their shoes and starting from a place of empathy. Again, even if you can just do this for 30 seconds a day, can start to build that understanding and make things feel a little bit more tolerable. Other behavioral triggers that we might experience with the person that we're caring with, is physiological. So if I'm in pain, right? If I am in pain as I am right now with all of my capabilities, I can sit there and be like, oh my gosh, I'm in pain. This hurts. Ouch. I don't know what happened. I need help. And I can problem solve for myself. Are individuals who are living with dementia who no longer have the capability to speak as they once did, who might not understand what that feeling is and then what to do about it, they might react. They might react by pushing you away when you come in the room to help them. They might react by curling over and refusing to sit up straight. You say, Ma, sit up straight. What's wrong with you? Ma, sit up straight. What's wrong with you? And kind of go into that cycle. What we want to do is try and assess for pain. As a professional, if Lindsay was to see someone, right, and she'd notice as she's coming over to touch a person or to take their vitals, that they, push away, one of the things that she might see is, are they in pain? This is new. And so usually that's an indication of pain. Lindsay talked about the hallucinations and delusions. I think a lot of times for, everyday people, hallucinations and delusions sound really scary, but I've always liked to find out what a person's hallucination and delusion is because it interests me, and then kind of go with it. So like Lindsay mentioned, it could be something that's really positive, like little people doing Broadway. Did you say little people doing Broadway shows or just people doing Broadway shows? Little people doing Broadway shows. Oh, that's fascinating. I want to see that. Okay. So it could be really cool, or it could be my cat that I had from childhood, or I could be sitting next to my mother who's passed away years ago, but I don't realize it. There's a woman who I see every day, and she has a little girl that sits next to her, and she's always telling me about the little girl. And I'm not sure if it might be a daughter that she lost that we don't know about, or if it's a sister or what it is, but it makes her so happy to talk about this little girl. And we're down with it. We're just like, let's go. And that's kind of rolling with what the person's delusion or hallucination could be, kind of joining them in their reality, which a lot of times can be a whole lot easier than trying to bring them back into our reality. That's an unrealistic expectation. And then this last little bucket here, again, Lindsay mentioned some of these things like overstimulation. If you're home, I walked into a family's home, oh gosh, probably right before COVID hit. The wife had a fax machine like ringing, which I didn't even I haven't seen a fax machine in so long. So I was like, what is this? A fax machine was ringing, her home phone was ringing. She's talking really loud, the TV's on, the radio's on, and there's a dog barking. And I was like, oh my gosh. And she's like, I don't know. He's just losing his mind all the time. And I was like, I'm losing my mind right now. There's so much happening in this apartment. Like, how can we streamline some of the overstimulation and the noise and the stress? And I have a hard time with stimulation just as I am right now. And so I get it. There's just too much happening. Can we turn down the TV? Can we maybe have a quiet space for dad to go or for mom to go? And if we do, we might see, again, a reduction in those behaviors. Other things that can kind of pop up that I always like to mention is that feeling of restriction. We have two ladies right now who love to just fidget with their shirts and their bras. And what we've been finding is they've been taking their bras off in the middle of programs, which again, you go on, girls, you do your thing. But some people find it a little disheartening. But what's happening is they feel restricted by their bras. And anybody in here might be able to relate to that. You might want to just put on a sports bra or just, relax a little bit when you get home from work. And so our individuals living with a dementia are no different. And so we want to think about that as well. Are their clothes too restrictive? Do their jeans feel a little bit tight? Again, some of you on this call might be able to relate to that, where you're just like, my jeans are a little tight. Want to wear the sweatpants. I realized the other day, actually, I hadn't worn jeans in a year, and I did family photos and put a pair of jeans on. I was like, I don't wear jeans anymore. I just don't. Thank you, COVID. Never wear jeans. And it was uncomfortable, and I felt restricted. And as soon as I could, I put sweatpants on because I have the capability of doing that. Our individuals who are living with dementia don't. And so they might fidget, they might get frustrated, they might disrobe. in places where it might not seem acceptable to do so. And that can be seen as like a problematic behavior. But if you just get them adaptable clothing or perhaps a looser fit of pants, and COVID was great for that. A lot of elastic waist pants came into fashion with COVID. So we get a few things like that, and it's a whole lot easier. It also allows me to be more independent because I don't need that assistance with the buckle, with the buttons, with the zippers, things along those lines. And if I feel more independent, then I'm going to, again, have less frustration and stress around the rest of my kind of capabilities or lack thereof. So that's all I have on behaviors. And as I said, I can talk all day about everything else and this, and I have talked all day about it. So what I'd love to be able to do, and I don't know where we're at for time, I just have no clue. But what I'd love to be able to do is to open this up, as if I can. I'm running the show. I'd love to open this up if I can, Ellen, to the questions for Lindsay and I.
Sure, why don't we put Lindsay and you together?
Okay.
If we can figure this out and finally do something right. There.
Oh, nice. Yeah.
And Laura, I think is going to, well, I know, is going to facilitate the questions. And we'll either start with those or something spontaneous. So Laura, I'm going to turn it over to you.
Great. There are a couple of questions in the chat, but before we get there, Molly and Lindsay, I wanted to know if you had questions for each other.
I have many questions. I have a lot of, I think, something that, comes up a lot for me, again, as the physician, people sort of, you want me to help with these problems. And I'm like, yeah, I think we should try some behavioral strategies. And I sort of do some hand waving and kind of vaguely suggest them. But I think, we certainly, I was telling these ladies in the preparation for this that, in medical school and even in specialty training, I think there's a huge emphasis on the medical management, medications, treating this like a medical illness, and really a lot less on the kind of how to sort of approach this as sort of a holistic sort of whole with this person at the center, and the medications are a part of it, but also all these other behavioral strategies. And I think, I don't know if I have anything specific right now other than that I want you to teach me your ways so I can share them with people.
Well, and I'm really appreciative of the fact that you're not just like pushing medication all the time. I think it's really important. And for all of you on the call too, I think it's important to realize that medication's not going to solve everything. Like Lindsay mentions, it's just one piece of this big puzzle. And even like the antipsychotics, and you mentioned this briefly, and again, I'm not a doctor, I'm a social worker, but like antipsychotics can be really great for some, but it's not going to make the fact that I'm uncomfortable or overstimulated or bored go away. And so I think sometimes families or institutions too can say like, oh, well, let's just go ahead and give some Haldol, it'll make everything better. And actually it might not. So I'm really appreciative of you, Lindsay, taking that approach. And for those of you on the call, I think it's important for you to find physicians who aren't just looking to push medication, but really trying to figure out how to meet these needs. And what else was I going to say? Meet the needs, and then also remember the human here, because I think that's what gets lost so often, is the human being who has had this whole life's worth of experiences and expectations and capabilities, and it's being taken away without their consent. I think that's really important.
Ready for a few questions?
Yeah.
Yep.
The first that we received was a question saying, do we really know that amyloid plaque is correlated with Alzheimer's?
That is an excellent question, and one that has, is come up a lot because, not to get too much into the weeds on this, but Aduhelm, the new drug, aducanumab, the way that drug works is it clears amyloid out of the brain. And this is based on this hypothesis that, amyloid buildup is part of the problem, is a cause of Alzheimer's. And we don't totally know that that's the case, or is it just that this is a side sort of effect of a process that's happening and causing this and other things. The drug in the two major trials that they had run with it initially actually failed on their clinical endpoints. And then they got it approved on an endpoint showing that it clears amyloid. But we don't know that clearing amyloid actually is clinically beneficial. And so that's kind of where all the controversy is around this drug. And I think, there are There is still a lot of interest in the amyloid hypothesis of Alzheimer's, and it probably is playing a role, but it probably is not the entire picture.
So interesting. This is maybe a question more for Molly, and actually something we've talked about in our group during the weekly meetings. But this is from someone who's saying that they have to find care and support for a family member who they don't live near. So it's how do you go about finding support like a caregiver while you are living across the country and you are the only family member? I know in our group we've invited on senior care managers who can really assist with that, but could you elaborate?
Yeah, I'm a big fan of geriatric care managers, especially if you're a long distance caregiver. My sister is one, but that's not why I'm a fan of them, just to be clear, but she's a great one. And it makes so much sense. So for those of you who aren't aware of what geriatric care managers do, they're basically like the daughter you never had in a different city who can take care of everything, or like the personal assistant. My sister has done everything from help people buy cars to televisions to bring care in to like help plan a funeral, like everything and anything. There's a group called ALCA, Aging Life Care something or other. I'm sorry, I don't remember what they used to be Geriatric Care Manager Association. It's called ALCA, ALCA, and I think it's .org. And they have a listing, so you can find geriatric care managers who are licensed as such, professional association around the country. I can provide a ton of resources for here in New York City. I'm quite familiar with some great ones here in New York. If you're in Rhode Island, you can talk to my sister. But yeah, so that's the first great thing. The other thing would be to pair with great organizations like HFC, who is our sponsor tonight. HFC is fantastic. They have social workers that you can talk to. They have support groups that you can talk to, and they can also connect you with folks around the country. Where I used to work, the Alzheimer's Foundation is wonderful in that they have a national toll-free helpline. And what's different about their helpline than like other places is that it's staffed by licensed social workers. Some of whom I hired and are still there, which is awesome. And so I think having a licensed clinician on a helpline that you can call at 7 o'clock at night or at 7 in the morning or whatever can be really valuable versus a trained volunteer. And maybe I'm a bit of a snob about it, but I just think anytime we can get a licensed clinician on a phone, we're more efficient and your time is super valuable. So those would be my suggestions. And then for yourself, if you're long distance and you're caring for a person in another part of the country, make sure you get yourself some support too, and give yourself a break, because you can't be everywhere all at once. And it's super hard, and there's a tremendous amount of guilt, and it feels crappy sometimes. But building a great team for you in your current location and the location of your person, they're super helpful.
If I could just also add, I think, I guess more for, less sort of remote stuff, but just I was thinking about the geriatric care manager. I'm curious your thoughts, Molly. I think one of the things that I see, I think often people, are reluctant to do that, or kind of don't feel that they need it or don't want to like outsource the care for their loved one. But I find that actually, if you do that, it allows you to actually sort of resume the relationship that you have with that person and not be,
100%.
constantly telling them you have to do this, do that. It's like you can kind of let someone else do that and be the wife, be the daughter,
100%. I'm so glad you mentioned that. Absolutely. Yeah. It's kind of like getting somebody to do all your dirty work. And you can just go back to building that relationship and find the opportunity and joy of being in the moment with your person without having to worry about like, oh my gosh, I've got 1 week to be with them. I need to clean their house. I need to do all this, blah, blah, blah. You've already got somebody on hand to do that for you. So this way you can go ahead and just, be the daughter, 100%. And there are some that can take, some geriatric care managers may take long-term care insurance, but oftentimes it is a private fee. And so do know that can be, it can be a financial burden for some. And I think that there might be some that you can find who take other insurances.
Molly, here's another question. Somebody asks about their frustration with dealing with a parent who doesn't want support, but they feel it's necessary to keep them safe. I mean, this is such a common story that we hear. Any suggestions?
Well, I mean, first of all, think about like what you want to keep them safe. Is that like they don't want to shower every day and you want to keep them safe? Is that really a risk? Like, so like reevaluate, like, what is your freak out about? And I don't mean to minimize by saying freak out, but like, what's happening here? Is it that they keep driving and they've gotten in 10 accidents? That would be a risk. That would be a safety issue for you, for everyone on the road. But if it's that they just got diagnosed yesterday and you feel you need to take the car away, even though they never drive it, that's not a risk, because they never drive their car. And so it's first pause for a second, maybe ask a neutral friend, or you can like call me. Just be like, okay, is this really a risk or is this just me freaking out? The challenge is with our parents are super proud, right? And this generation of people are like, I don't need your help. I'm cool. Who are you? You're my daughter. You don't know. You're my son. You don't get it. And so you're right. I don't. But how about we want to, I love you so much. We want to keep you around. I'm worried about X, Y, and Z. So how can we find a common ground? You can also, if it's something like you're worried that they're going to wander or get lost or disoriented, there are things like the tile that you can attach to their keychain. You can do a find my phone, like iPhone thing. I don't know how to work that, but I'm sure most people do. You're all like, yeah, I do that on my kid. I don't know. So yeah, you can do something like that. I think it's tricky, and it shouldn't be an expectation of I'm going to sit down with my mom and I'm going to have this conversation today. This is a work in progress, and you may still lose. And it may take, sadly, and it's scary, but it may take a crisis for somebody who's so proud to see that, oh my gosh, maybe I do need to make a change. And so all we can control is all we can control. And oftentimes we can't control another person, if that makes sense.
And sometimes if you're a family member, it's a great idea to lay off these decisions on somebody else. I know for driving, there are driving assessment places that you can take your parents and they can tell you whether it's safe for them to drive or not. And
yeah,
then,
Lindsay can go ahead and write you a prescription for that. Blame it on the doctors.
Oh,
That's
listen, I tell people, I'm like, listen, make me the bad guy. Like, this is, much of my, like, I have visits that are just for this, where I'm like, listen, you can't do X, Y, Z. But I think it's, it's interesting. I was like listening to you talk, and it's like both, with my parents who have medical stuff, and also in my role as a doctor here, I think I've had to sort of adjust my sort of mental goals from like, okay, let's make everything, like, do everything perfect, make it all like 100% safe. Everything has to be sort of like medical, like, like everything that, sort of standard of care. And you actually can't always get it to be perfect. And that might not be what, this person needs. And so, sort of accepting that, okay, they'll only take one pill. Which one, which one do we want you to take, as opposed to being crazy about like, oh my God, he's not taking the aspirin and he's not taking this one, and so, yeah, sort of realizing like, you're doing your best, as you said. You cannot do more than you are doing, and there are limits to what is possible, and you're sort of making the best of a situation that is very difficult.
Yeah, I think and there's a few different ways, right? So with my father, there were three of us. My sister, the geriatric care manager, the queen, the one who does everything right. I'm the youngest, happens to be a memory care expert. I know nothing, I know nothing. And then there's my brother, who was like, there's no problems here, right? We all family dynamics. Let me tell you about that. That's a whole other training. But so with me, what I did with my dad, because I was like, he knew something was wrong and he was able to acknowledge, I know something's wrong. And at the time I was like, Dad, there's still, I wasn't married. I said, I want you to be here for these big things that are going to be in my future. I don't know when, but they're going to be in my future. So I took the heart approach, the emotional approach. And I said, I want you to get whatever help you can get. I want to go to the doctor. Like, let's start talking about this. It's going to be scary, but you're not alone, because there's still a lot of life that you have to live and a lot of things that I want you to see. And that seemed to work for a little bit. And what we found with him, and I feel like we were really fortunate, is that he was able to self-select out in ways that I know a lot of other people aren't that lucky. So he, stopped driving on his own. He, stopped driving on his own. He stopped trying to do like paperwork and like financial stuff on his own, because he realized that it was getting too difficult. Now, he still had an emotional piece on it, but there wasn't that back and forth fighting, which we were lucky on. But I know that a lot of other people will just fight about silly little things like, he's not eating the blueberries, and I read that the blueberries are going to cure his brain, and if he eats more kale and eats more salmon, everything's going to be great, and why does he only want to eat ice cream? dude, let them eat ice cream. Like, it's cool. Like, eat ice cream, live your best life. If only we could all eat ice cream all day long, we'd be okay, unless you're diabetic. And then I'm sorry, Lindsay, you can yell at me for that.
Yeah, but I think it's, I think it's such an important point. I mean, I think what you did with your dad is so nice there, where it's sort of like you found a way to kind of align both of your goals, right? So it's not that we're fighting about this. It's like we actually both want the same thing. We both want you to be here for me to have these things. So how can we make that happen? And it's like, my dad is older and chronically ill and depressed. And again, I'm a neuropsychiatrist. I'm like, you're depressed. No, I don't know anything, right? Nobody cares. So
Nothing, yeah.
right, I know nothing. He's like, I'm not sad. I'm like, you don't leave the house, you don't do anything. Like, you seem very sad. So, but I was like, oh, I see that you're upset that your appetite is down because of your illness. And I was like, I think if we increase your Zoloft, that might help your appetite. And that was okay. And he accepted that. And that, we were able to sort of change the language. It didn't have to be like we're arguing about, are you depressed or not depressed? It's like, okay, we want you to eat more. And so if you can sort of like kind of figure out where these conflicts are and maybe just sort of reframe it so that it's like actually want the same thing. Let's not argue about that. You can get further.
Yeah, try and steer clear of the tug of war. If you find yourself getting into that gripping battle, no one's winning. And if you have other people, even if you don't like your siblings or you don't like, your parents or whatever, if one of them can be a nice distraction, and then you can kind of rework into the conversation in a little bit. But this is like a slow and steady, like Lindsay said with the medication, like slow and steady type of thing. This is a slow and steady. This is, to me, if you do like an ambush, it's not usually going to work well.
I think we have time for 2 questions if we make the answers fairly brief. We have one question from someone who has a problem deciding which doctor to listen to. And I think she's talking about probably more mental health meds, and it might be, I maybe want to step back from that, which is to say, Lindsay, many people seek help from you, but you might also explain sort of the choice of people. Probably most people are going to start with a gerontologist, but at what point would someone bring a parent to you, and what are the other professionals they might be looking to talk to, and how would you evaluate, advice given to somebody when it's conflicting from different doctors?
Yeah, it's a good question, because there often are a lot of doctors involved, and it's, there's the gerontologist, there's me, and I function here a lot of the time as sort of a regular cognitive neurologist, in addition to sort of doing the neuropsychiatry part, if that's relevant. But there's often like cardiologists and, other medical specialists who are like, this person needs this medicine. I'm like, this medicine is making them, I think, very slow and very, sad. And, it's, it can be difficult to navigate that. I think, one thing I will say is that all of these medicines, certainly the ones that we're using for mood and behavioral stuff, they're all off label. It's all a little bit kind of educated guesswork. And so people will have different suggestions. It doesn't mean someone is wrong. It just is sort of like, in their experience, this is kind of what has worked for this kind of thing. I think that what I would say is really the most important, whether or not the person really kind of knows a lot of data or sort of has a large armamentarium of medications. I think if the doctor appears to listen to you and, kind of it takes your input, understands what you're saying, treats your parent or, love them like a person, and really is, kind of seems to be aligned with you in terms of the goals. And I would stick with that person. Sort of, I think the communication style with a physician is very important.
Good. And Molly, maybe I'll throw the last one to you. It's a little bit of a combining 2 questions. One is, dealing with someone who has dementia. I think sort of really 2 questions. One is, should you talk to the person about their dementia? How do you handle that? And then also tricks to try to distract someone who might be depressed or lethargic or despondent. Any particular ideas for engaging to, that are particularly good?
Okay, so in terms of the tricks and tips, by the way, what I say might work for one person today and not tomorrow. And so we always want to have a bunch of tools in our tool belt. It sounds super cheesy because it's just, you're going to need a lot happening. So in terms of the tricks and tips to try and get somebody active, I think one, we need to use the word, and Lindsay used this word earlier, reframe what active is. I might say, no, I don't want to hang out with you today, or no, I don't want to do anything. Okay, can I just sit with you? And for you, the person who's going to be doing the sitting, can you sit in silence? And that's like a thing they taught us in like therapy school, right? Like, how do you sit in silence and tolerate silence? And it can be really uncomfortable. But I think it's an important thing, and I would do this with my dad, is just to sit with him. So if he didn't feel like doing an activity, I'm not going to fight with him. But certainly if he's like, well, I don't want to do anything, but slowly he would talk, or I would put music on because he really liked listening to show tunes and he likes Barbra Streisand. And so I got him a little Bluetooth speaker, and we'd sit out on the porch and we'd just listen to music together and not talk. And he'd doze a little bit. Sometimes I would try and have just like small bursts of conversation, but felt like sitting with him, not alone, was certainly better than being on his own with his own thoughts that might not be so positive. And I don't know always what his thoughts were, but I think he got sad and didn't like that he was sick. And kind of speaking to would I address a person about their dementia, I would say, again, it depends on the person. I'm not one to lie. And like people who say, oh, I would never tell my mom she has a dementia, I'm not usually on board with that. I think that there's ways that therapeutic fibs can come into play. And we see that a lot when somebody's transitioning into a care setting. Your house is under construction, so you're going to just stay here for a bit. That gets them into a safe space, and that can be okay. But at some point, you've got to realize you're not going home, and you may need to have that conversation. For some people, and again, I'll use my dad as an example, and I don't think he's unique in this. I feel like all of our people know that something is changing, especially earlier on. They know something's changing. Our people are not dumb, right? I recognize I can't remember things anymore. I can't keep up at canasta. I don't know where I'm going. I get a little confused, and they don't want to talk about it because they don't want to be, whatever their worst fear is. They don't want to become, for my father, he didn't want to become his uncle. I don't want to be like him. And so we talked about that and how, well, you're not really going to be like him. Everybody's a little bit different, and you're different, and we're different. And so we're going to be whatever it is that you want to be, which was sitting on the porch listening to show tunes. So I would talk to him about his dementia. I don't think my mom ever did, but I also don't think she was comfortable in talking to him about it. Same with my sister. So it's really, you have to be comfortable in having that conversation first and foremost. Figure out if you're saying, well, maybe I should not, maybe it's going to make them sad if I talk about it. So what's wrong with being sad, right? Like sometimes we need to be sad to be able to move a little bit more, like move the needle a little bit more, just like you guys all deserve to be sad some days. Like, it's okay. It's not our best day, but like, it's okay. So allow yourself to feel, and then allow yourself to just be in the moment with them. And that moment could be long, it could be short, and they also might not remember it tomorrow. For my dad, he always said he did remember our initial conversations, and he, I think, knew, and maybe this is just the fantasy I tell myself, but I think he knew that I was a safer space to talk about some of the things that he couldn't talk about with my mom. And I was really happy to be that person for him.
I think I would just add also, I think that was, super helpful and comprehensive. I think, this comes up, I think for me a lot also because people are seeing me to get a diagnosis, and then I'm doing, we're seeing follow-ups and like, what is the purpose of your visit here? And, why are you coming to, it says Alzheimer's on the wall. And I find that if people ask, I tell them, but a lot of people don't ask. And I feel like, if people are asking, then, it's sort of they are ready to know something. If they're not, then I just leave it. We'll have a conversation about kind of how things are, but not, directly address the diagnosis. But I think people, have a way of kind of, as you were saying with your dad, people way of showing you kind of what they're able to talk about and not talk about it, sort of will open the door if they are.
Yeah, I think it's just important. And to me, it's a fascinating piece. I'm such a curious person, but I'm curious to know, and I've talked about this in some of the lectures I've done and work that I've done. It's like, what do they think of when they hear the word Alzheimer's, or they think about Alzheimer's? Usually they have what I call like a boogeyman picture in their head of like that scary thought. So like I said, for my dad, it was his uncle. who had a incident of incontinence at a family barbecue, and it just like scared the crap out of my dad, no pun intended. But so that was like a situation, right? And so I'd be curious to know that, because some people have it that I'll end up institutionalized and think of like a one flew over the cuckoo's nest type situation, and that's not what care settings look like. They don't understand, you know, how modern like senior living facilities, things like that. And so, or they don't understand that care can be done at home, and they don't understand, you know, so I like to always know, if you feel comfortable, or if you have a geriatric care manager, or working with Lindsay or whoever your physician is, and saying like, well, what do you think? Like, what do you think's happening with you? And again, it's easy for me to do this as a non-physician, but like, what do you think's happening with you? What are you worried about? What's your worst fear? And like, go there, so then you can kind of work back and debunk some of these myths. And if we put it all out there, which again can be scary for you and scary for them, then it doesn't feel so closeted, and we don't have as many secrets, and we can have a much more open conversation when changes happen, which will also have a reduction in these behaviors. Because if I don't have to hide things from you, then I won't have to try so hard, and then things will just feel more comfortable and safe. And all anybody wants, ourselves included, right, is to just feel safe. And we're dealing with an illness that makes us feel a little bit unsafe. So if I know I feel unsafe with my illness, but I feel safe with you, the doctor, or you, the daughter, then that's helpful.
What a great response.
Thank
Both
you.
Both of you are terrific. This has been so wonderful. Here, let me turn on Hallie, who has a couple of quick closing remarks.
Hi, I just wanted to say thank you for joining us tonight. Sorry for the glitches in the beginning. We're going to run the video without glitches now, so that you can see it to say goodbye. We want to thank our participants, and we want to let you know that we've been looking at our mothers in this one, but in the next one, we're looking at ourselves. We're looking at how we maintain balance, what we do to have balance in our lives, to deal with the frustration, to deal with the disappointment, to deal with the ongoing loss, because as we're caring for our mothers, there's also a sense of loss while they're alive. And I think there are a lot of things that we're going to be looking at. Many of us are mothers, many of us are daughters, many of us have siblings, and I think we're going to take all of that into consideration at that level next time. So we hope that we'll see you again. We hope that you'll be inviting other people. And we want to say thank you so much for coming, as we're kind of reimagining this whole picture.
And I just want to say that there is a recording of this that we can make available to anybody who would like it as well. Thank you, everybody.